Hello, everyone. In this video, let us look at the difference between confounding and interaction. First, let us understand what is confounding. A confounding factor has four important characteristics. They are as follows. First feature is that it is associated with both exposure and outcome. The second feature is that it is an independent risk factor for the outcome. Third feature is that it is unequally distributed between the two groups, that is, cases and controls, or the study group and the comparison group. The fourth feature is that it does not come in the causal pathway between exposure and outcome. So, a confounding factor fulfills these four major criteria. To understand this concept of confounding, let us look at a hypothetical example. A study found that coffee drinking causes myocardial infarction. Now, this result is very concerning whether coffee drinking has any role in causing myocardial infarction. Here, smoking is a confounding factor. Because smoking is associated with both coffee drinking and myocardial infarction. Smokers generally smoke along with a cup of coffee. And smoking is an independent risk factor for myocardial infarction. Also, smoking is unequally distributed between cases and control. That means there were more number of smokers among the cases, that is, among those who suffered myocardial infarction, than among controls, that is, those who did not have myocardial infarction. Because smoking is associated with coffee drinking, they found a spurious association between exposure and outcome. And finally, smoking does not come in the causal pathway between coffee drinking and myocardial infarction. That means smoking is not the result of coffee drinking. It is just an associated factor. Now let us try to understand what is causal pathway with an example. Coffee drinking may lead to increased blood sugars over a period of time. This in turn may cause dyslipidemia due to various metabolic pathways. And dyslipidemia may finally lead to myocardial infarction. A question arises here as to why this dyslipidemia cannot be a confounding factor. Dyslipidemia may be associated with coffee drinking, that is, coffee drinkers may have dyslipidemia, and also dyslipidemia is an independent risk factor for myocardial infarction. But since dyslipidemia comes in the causal pathway between coffee drinking and myocardial infarction, it cannot be considered as a confounding factor. Moving on to the next concept, which is interaction or effect modification. These are synonymous terms. When the incidence rate of disease in the presence of two or more risk factors differs from the incidence rate expected to result from their individual effects, we say that there is an interaction or there is a role played by an effect modifier. Another way of trying to understand the concept of interaction or effect modification is as follows. If the association of exposure on the outcome is of different strengths in different strata formed based on a third variable, which is the effect modifier, then we say that there is an interaction or effect modification. Now let us look at two scenarios. In the first scenario, we will be looking at the association between air pollution and lung cancer. Here, smoking is the confounding factor. In the second scenario, we will also study the association between air pollution and lung cancer, where smoking will act as an effect modifier. At first, let us study the first scenario. You can see in this 2x2 table that, looking at the columns, there are 450 cases of lung cancer, that is 300 plus 150, which is 450 cases of lung cancer. Similarly, there are 5,550 people who do not have lung cancer. That is 1,700 plus 3,850, which is 5,550 people who do not have lung cancer. Also, looking at the rows, we have 2,000 people who are exposed to air pollution. That is 300 plus 1,700, which is 2,000 people who are exposed to air pollution. And there are 4,000 people, that is 150 plus 3,850, which is 4,000, who are not exposed to air pollution. When we calculate the unadjusted odds ratio, or the cross-product ratio, we will get a value of 4.52. Also, when we calculate the unadjusted relative risk, which is the incidence of lung cancer among the exposed, divided by the incidence of lung cancer among the non-exposed, we will get a value of relative risk as 4. Now let us stratify the exposure and outcome based on the presence and absence of the confounder. First, let us look at the association of air pollution and lung cancer only among the smokers. Assume that there were 2,000 smokers and 4,000 non-smokers. Now among the smokers we have computed the 2 by 2 table and we'll be looking at the association of air pollution and lung cancer. Here we will obtain an adjusted odds ratio of 2.25 and adjusted relative risk of 2. Similarly, among the non-smokers, who are 4,000 in number, we have computed the 2 by 2 table to look at the association between air pollution and lung cancer. Here we have obtained an adjusted odds ratio of 1.55 and an adjusted relative risk of 1.5. So what we can conclude from the result is the fact that both the adjusted odds ratio and adjusted relative risk among the smokers, as well as non-smokers, is much lesser than the unadjusted odds ratio and unadjusted relative risk. It means to say that when we eliminate the role of the confounder, we found that the adjusted odds ratio and adjusted relative risk was much lesser, which clearly points out to the role of confounder in the association between exposure and outcome. You may still question that the adjusted odds ratio and relative risk is greater than 1, which means that the exposure is still a risk factor. Here we are not sure of the role of air pollution as a risk factor. We have eliminated the role of one known confounder, which is smoking. But there may be even other confounders which we may not know, and may be playing the role in association between exposure and outcome. Before proceeding to the next scenario, just for the simplicity of calculation, I would like to inform you that we will keep the number of smokers and non-smokers constant. Also, the number of people exposed to air pollution and not exposed to air pollution also constant. And then we will proceed like a cohort study to find out how many people will develop lung cancer among the exposed and non-exposed, if smoking will act as an effect modifier. We will calculate both relative risk and also odds ratio. Now, moving on to the second scenario, let us calculate the association between air pollution and lung cancer if smoking were to act as an effect modifier. We can compute the 2 by 2 table, assuming equal number of smokers and non-smokers as the previous scenario, and also equal number of people exposed and unexposed to air pollution as the previous scenario. So, just like the previous scenario, we will have 2,000 smokers and 4,000 non-smokers. And also 2,000 people exposed to air pollution and 4,000 people not exposed to air pollution. Here we will obtain an unadjusted odds ratio of 5 and an unadjusted relative risk of 4. Now, let us consider the second scenario, where smoking will act as an effect modifier. When we stratify based on the smoking status and look at the association of air pollution and lung cancer among the smokers, we will get a very different result. We have a higher proportion of people having lung cancer among those exposed to air pollution. As a result, we will obtain an adjusted odds ratio of 12.66 and an adjusted relative risk of 8, which is much higher than the unadjusted values. Similarly, for the non-smokers, we have similar results, as we had seen in the first scenario. Whether smoking is a confounder or effect modifier, but for non-smokers, we will have similar result in the two scenarios. Even here, the adjusted odds ratio is 1.55 and the adjusted relative risk is 1.5. In conclusion, we can say that, in case of a confounder, when we stratify, the adjusted values will lie only on one side of the unadjusted value. In case of an effect modifier, when we stratify, the adjusted values will lie on either side of the unadjusted value. To explain this in detail, we can say that, If the factor is a confounder, the adjusted values will lie only on one side of the unadjusted value. Whether the adjusted values will be higher or lower than the unadjusted value will depend on whether the confounder is a risk factor or a protective factor. If the confounder is a risk factor, the unadjusted value will be higher, and when we eliminate the role of confounder by stratifying the association between exposure and outcome based on the confounder, then we will get lower values of adjusted odds ratio and relative risk. Similarly, if the confounding factor is a protective factor, the adjusted values in the presence of the confounder will be higher than the unadjusted values. Next, looking at the effect modifier, we can say that the adjusted values will always lie on either side of the unadjusted values. If the effect modifier is a positive effect modifier, then, in the presence of that effect modifier, the adjusted value will be higher than the unadjusted value. In case the effect modifier is a negative effect modifier, then the adjusted value will be lower than the unadjusted value. Hope this will clarify the difference between confounder and effect modifier, or confounding and interaction. Thank you very much for your patient listening.